This is a brief presentation on acute cholecystitis, diagnosis, treatment, and management by Sanjeev Bagga, MD. The past medical history may be relevant with prior history of colic. The patient may be an obese female. There is history of intolerance to fatty food, and there is history of gallstones on ultrasound. Present history may consist of history of colic, history of acute upper abdominal pain, history of nausea and vomiting, and right subcostal tenderness. Acute cholecystitis results from obstruction of the cystic duct by a gallstone. Typically, there is pain on palpation of the right upper quadrant of the abdomen and on deep inspiration, which is described as a Murphy's sign. There is involuntary guarding of the upper abdominal muscles on the right side. Although the history and physical examination are helpful, the diagnosis is made by an ultrasound, which demonstrates gallstones, thickened gallbladder wall, which is typically more than 3 millimeters fluid around the gallbladder. A positive Murphy sign, which means that on pressing the ultrasound probe in the right upper quadrant, the patient experiences pain and tenderness. The labs may be slightly abnormal, such as there may be increased white cell count, but the LFTs are typically normal. Patient is typically managed with administration of IV fluids, analgesics. Patient is not given anything by mouth. Nasogastric suction is applied if patient is vomiting or has ileus. IV antibiotics are given, though the evidence is lacking as far as benefit is concerned. Empiric coverage against gram-negative enteric bacteria with IV ceftriaxone and metronidazole is given. Untreated, the patient may develop complications. Without treatment, about 10% of the patient develop localized perforation, 1% develop free perforation and peritonitis, increasing abdominal pain, high fever, and rigors with rebound tenderness or ileus suggests empyema or pus in the gallbladder, gangrene or perforation. When acute cholecystitis is accompanied by jaundice or cholestasis, partial count bile duct obstruction is the likely cause due to inflammation or stones. Multiple complications are seen. One of the complications is described as Mersey syndrome, where the gallstone is impacted in the cystic duct, compresses and obstructs the corn bile duct and causes cholestasis. If the gallstones pass from the gallbladder into the biliary tree and block the pancreatic duct, pancreatitis results. If a large stone erodes the gallbladder wall, creates a fistula into the small bowel or into the abdominal cavity, the stone may pass freely into the abdominal cavity or it may obstruct the small bowel, which is known as gallstone. Ileus and the phenomena of the stone passing from the gallbladder and creating a fistula into the small bowel is known as cholecystoenteric fistula. Acute acalculous cholecystitis. The symptoms are similar to acute cholecystitis. However, the patients are typically very severely ill. Abdominal distension or unexplained fever are the only clue. Acute acalculous cholecystitis. The patient has no gallstones. There is a positive ultrasonographic Murphy sign, thickened gallbladder wall, and pericholecystic fluid. Untreated acute acalculous cholecystitis may progress to gallbladder gangrene, perforation, sepsis, shock, peritonitis, and has a mortality of about 65%. Acute cholecystitis during the acute phase is typically managed medically. If complications such as an abscess develop, even these can be managed by image-guided drainage and not by open surgical procedures. However, surgical cholecystectomy is the definite treatment for gallstones, usually performed a few weeks after electively once the acute symptoms have subsided.